Hello, everyone. My name is Michelle Petri. This is a Room Now hydroxychloroquine update from the American College of Rheumatology meeting. And you can see I'm going to cover a lot of different presentations. Let's start with a brief summary of why hydroxychloroquine should be background therapy in all lupus patients. And I've circled at the bottom, please never forget, this is the only medicine that improves the survival of people with lupus. And you can see that's been proven by multiple research groups, including my own. Our paper is the one headed by Deanna Hill. So I thought you'd be very interested in this study. This is from the Systemic Lupus International Collaborating Clinics cohort, which is an inception cohort. Natalie Costadoet-Shalomo, who pioneered checking hydroxychloroquine levels, looked at hydroxychloroquine levels, and she had to use serum, but she made a very simple correction to get them close to what a whole blood level would have shown. Now, in one of the figures shown in her presentation, you can see that with severe non-adherence, there's a difference in time to damage, but she also saw an increase in mortality. So you can add this to the many studies now that have proven an important reason why everyone should be on hydroxychloroquine, even if their skin and joint lupus is under good control. Don't stop it. But here's a study where the study itself was not about hydroxychloroquine, but then Murray Urowitz went up to the microphone and pointed out something very important that I had missed. So this is a study from April George. She's one of the, up and coming superb investigators in lupus who looks at big data sets. And she was actually presenting on the contemporary incidence of lupus nephritis from a large national data set. And what Dr. Urowitz pointed out was here under medication use, just see hydroxychloroquine, 39% or less. And this is a database of people with insurance. There's no access to care issue here. So isn't this atrocious? In academic centers, we won't be at 100% because some of our patients will have either intolerance, a true allergy, or will develop retinopathy. But most academic centers are going to be like 85, 90% hydroxychloroquine. Why isn't this message getting out into the community? So I wanted to remind you of some wisdom from C. Everett Koop, one of our very interesting surgeon generals. And he was the one that said drugs don't work in patients who don't take them. And unfortunately, what's happened, I'm afraid, is because of the ophthalmology guidelines, people are being prescribed less hydroxychloroquine, not just that they're not prescribed it at all. So I wanted to remind you of a second very important finding from our group, which is that the prescribed hydroxychloroquine dose has nothing to do with the whole blood level, which is what determines efficacy. In the red line, you see 1,000 milligrams, which is our goal for the whole blood level, not this 5 milligram per kilogram rule. We have to individualize it so that patients are getting an effective whole blood level. Now, here's the next abstract that I thought was really instructive. And this was supposed to be a belimumab abstract, the goal being to show, as it did, that belimumab reduces renal flares in the combined GSK database. But there was a very interesting finding, which is that hydroxychloroquine use reduced the risk of renal flare. You can see the hazard ratio went down to 0.66, and the p-value was very significant. Our group and others have shown that hydroxychloroquine use prevents or reduces later kidney damage. This may be one of the mechanisms. So hydroxychloroquine is in all the lupus nephritis guidance documents. It needs to be bold print, I think. But there are concerns, and these are real concerns about hydroxychloroquine in the heart. And so the first concern is hydroxychloroquine in that very rare adverse event of cardiomyopathy. Now, here's a study of heart failure with preserved ejection fraction, and it's being done in both lupus and rheumatoid arthritis. And in fact, hydroxychloroquine had a negative association with heart failure. So although there will be those rare cases of hydroxychloroquine cardiomyopathy, overall, hydroxychloroquine is good for the heart muscle. What about QTc prolongation? Because you remember that came up during the COVID burst, where hydroxychloroquine was being given when, of course, it turned out it didn't work, but along with the fact that COVID was in the heart and patients were on antibiotics that prolonged the QTc. Now, have we put this to rest? No, I don't think so. And so here is a study from one of my former lupus fellows. So I'm so glad to see her still involved in lupus research. And here's what they found. They did find quite a bit of prolonged QTc. They didn't find bad arrhythmias. And the mean dose of hydroxychloroquine was really quite low. It was 276. So their conclusion was QTc prolongation was increased with hydroxychloroquine users, but it did not reach statistical significance. Now, I think this is the study that has a really important take-home message, meaning it's going to change how I practice this week. And that's that our patients are on so many drugs that prolong the QT. In particular, as you know, 30% of people with lupus also have depression. So in this presentation, you can see the multiple factors that prolong the QT. It's not just hydroxychloroquine. And you can see that cardiac disease in and of itself and cardiac manifestations, but there are antidepressants. So I think now that I'm going to change my practice, and if the person is on an antidepressant and HCQ, I will get a baseline EKG. Before this presentation, I was sort of very laid back and not bothering to do EKGs. So every time I go to the ACR meeting, I learn something. I want to thank you for listening. I want to remind you that Room Now is there for you at the ACR, but every day of the year as well. Thank you.